Hello and welcome to today's in-service. The next 10 minutes will address the ways in which ICU-associated delirium can be effectively managed to improve patient safety across a variety of domains and contribute to our overall goal of maintaining a healthy workplace. Research has shown that between 30 to 50% of Australian intensive care unit patients experience delirium in any given 24-hour period. This is quite alarming and has the potential to impact on the safety of the patient undergoing a delirium, as well as the patients whose nurses leave that bedside to assist with escalating situations, particularly when restraints and drug checks are required. Under-detecting delirium threatens the ideals of a healthy workplace because of the elevated care burden, workload, psychological pressure and risk of injury reported by nurses in the ICU. Furthermore, the psychological pressure and workplace stress caused by disorganised management of patients experiencing delirium can lead to nurses having difficulty with decision-making, whereby balancing risks and benefits can be incredibly difficult. This opens a great potential for the stress levels of the nurses as well as experience of other patients in the ICU to be collateral damage due to the high incidence and under-detection of a preventable and acute predicament many patients experience. Mismanaging delirium is a crucial problem because it is directly associated with substantial mortality and morbidity in ICU patients, but is not limited to the ICU. It has also been identified as a problematic and temporary clinical issue in neurological and geriatric wards. Furthermore, there is a significantly higher rate of mortality among patients who undergo a delirious episode during an ICU admission compared to patients who don't. You can see with this ratio why under-detection and mismanagement of delirium is such a problem. The literature suggests there is a low sensitivity and specificity in the ability of ICU nurses and medical specialists. This is often due to exhaust experienced by the nurses in ICU, feeling numb to the issue and therefore not communicating effectively with other members of the team. Nurses feeling desensitized to an acute situation such as delirium therefore carries major implications, not only for the safety of patients, but also for the maintenance of a healthy workplace when there is a critical breakdown in communication. The problem with under-detecting delirium is evidenced by a prolonged length of stay, increases in drug administrations, of opioids, administering surplus sedatives, which can all impact a person's future cognitive function and their outcomes, which I will discuss shortly. Research conducted through Monash University in Melbourne demonstrated that routine checks alone have been insufficient in reliably detecting delirium in a general ICU compared to the implementation of an independent nurse-initiated tool known as the confusion assessment method. The presence of delirium was then identified in 27 out of 35 general ICU patients. Please note this was in general ICU rather than cardiothoracic, neurological, or a severe trauma unit. Policy is being rewritten to highlight a pathway for the multidisciplinary team at all levels of training to follow. South Western Sydney Local Health District initially addresses prevention of delirium and impedes nurses to focus on the modifiable risk factors, such as lack of sleep, over-sedation and hypoxia, and aim to reduce the severity of such precipitating factors. Being able to better rapidly recognise and streamline delirium management is vital to contemporary practice because patient safety is at risk during delirious episodes. For example, patients often will require mechanical ventilation for longer periods of time, on an average of 1.79 days longer, plus placing them at greater risk of ventilator-associated pneumonia if they have an endotracheal tube in situ. Length of stay is also prolonged, thus exposing people to more pathogens and a greater risk of infection. Psychological safety is a major implication to consider, as it is at high risk of deteriorating during an ICU admission when people are not well rested due to lights, noise, discomfort, and a common sense of decreased autonomy, which is often reported. It is therefore vital to consider our patients' health in the future, rather than exclusively in our shift or during their ICU admission. This is a paramount aspect of person-centred care that can be overlooked in critical healthcare settings when life-sustaining interventions such as ECMO, dialysis and ventilation are being used. To improve delirium management is therefore integral to optimising outcomes for all ICU patients, their families and the healthcare team, reiterating its place in contemporary nursing practice. Effective leadership will help prevent delirium by taking initiative and advocating for patients in the forms of having more downtime with the lights, following protocols about visiting hours, and encouraging rest. These modifiable risk factors should decrease the incidence, supplementary to improve routine assessments with the CAM ICU, which has been proven to be a more reliable diagnostic tool when used properly by the nurses compared to routine head-to-toe assessments. Another vital aspect of positive leadership is assertive communication, whereby all healthcare professionals need to respond to delirious situations promptly and appropriately with both pharmacological and non-pharmacological interventions. Nurse leaders must also display self-awareness to motivate others to be involved with the push for better detection and care for patients who experience delirium. We know there is an inextricable link between effective nurse leaders and improved patient outcomes. Good leadership and therefore improving outcomes can improve the quality of the nursing experience of caring for patients with delirium. Mitigating the problem is thus likely to reduce the stress placed on nurses and therefore may positively impact on the incidence of burnout syndrome reported by several nurses in this environment when critical conditions like delirium are not addressed too appropriately. A study led by nurses in the UK calls upon nurses to view delirium as an acute brain injury, similar to a myocardial infarction or acute kidney injury. These are critical conditions that have clear, distinct protocols for acute management, and therefore delirium should be recognised as a clinical event for which safe and quality care rely heavily on effective prevention and acute management. This contemporary nursing point of view inspired my topic for today, as it succinctly illustrates why we need to improve our detection, management, and communication when patients in the ICU experience delirium. A study led by nurses in We need effective leadership in this area because nurses constitute more than 57% of the healthcare workforce. We can therefore be instruments of change, having the best knowledge of the patients at the bedside, and as new graduate nurses, being responsible for beginning our careers with the goal of optimizing patient safety and learning how to contribute to a positive, healthy workplace. We're also the most trusted profession and should take this seriously when patients and their families place their trust in us to provide safe and quality care. We need effective leadership. Patient safety and advocacy are at the epicenter of our profession, and we therefore are more concerned with ethico-legal obligations rather than boundaries in this domain. The NMPA RN standards of practice are highly relevant in showcasing our role in delirium prevention, detection, and management. Standard 1 calls upon us to think critically and analyse nursing practice. This is not only for reflection of our own practice, but of our teammates, in order to commit to quality improvement. Standard 2, engaging in therapeutic and professional relationships, reminds us to prioritise the person's healthcare needs within the context of their entire being, and be assertive communicators when a person is at risk of or is experiencing delirium in order to streamline care and optimise their outcomes with the entire MDT. It's great to have a multidisciplinary team, including students from the varying disciplines here today, to see what we can do to maximise the safety of those in our care and in turn foster a healthy work environment. I'm aware this presentation has been heavily nurse focused and I'd be more than happy to answer questions or discuss the information at the end. Put simply, the responsibility of the new graduate nurse, like all nurses, is to prioritise the safety of our patients and be their advocates. Remaining within our scope of practice would include being aware of the medications required when a medical officer orders them in the acute stage of delirium and following protocol. For example, please see the protocol from Liverpool I've used to inform the presentation. Like all emergencies, nurses should safely administer what is requested by the doctors, including performing the 3 checks and 5 rites, and document what was given when, and this should be charted in retrospect by the medical officer. Patient safety and advocacy. There is ample evidence in the literature placing importance on the therapeutic nurse-to-patient relationship and its effect on a patient's physical and psychological recovery. Hence, being more attentive with the CAM ICU or similar tool and the Richmond Agitation Sedation Score, also known as the RASS, from a person-centered approach rather than an illness-centered approach, is instrumental to the detection of delirium. Being diligent with the modifiable risk factors is also tantamount to prevention, as evident in the policy and aforementioned literature. The aim of today's presentation is to highlight how we can improve and enhance our lifelong commitment to learning. Our learning and application of practice keeps our patients safe and inherently fosters the growth of the elements required for a healthy workplace, also known as praxis. In-services have been identified to enhance learning outcomes due to the multiple learning strategies required. Today, we've incorporated written content, auditory strategies through narration, and moments for reflection with feedback to be completed after the presentation. This should assist with effective delivery and retention of the content about delirium management today to maximise learning to people's different learning styles. Participating in these in-services is a great way for us to collaborate and learn about how to improve our practice at the same time. If you would like to complete the feedback form, please do, and our educator will then approve 20 minutes of CPD points for registration. Thanks, everyone. The aim of today's presentation